Door closed. Okay, I think we're going to go ahead and get started. Looks like we've got a full house, pretty much. My name is Lori, and I'm here to introduce to you Dr. Christopher Keary. He's going to talk about anxiety and challenging behaviors in Angelman syndrome. Just a reminder, keep the cell phones down to a low level, please. And if the people in the back row or over here can shut the doors just to keep the noise out, that would be great. And we'll probably have time for questions at the end, so we'll go ahead and save them to the end. Okay? Thank you.
Thanks so much. I think we've got, if anyone wants, we've still got some seats, looks like in the corner over there, and there's maybe two up front here, maybe a couple here if other people are still looking for seats. How's everybody's energy level? Last session of the day, so hopefully energy level's still hanging in there. Long day, great. I'll try to keep it upbeat and to combat the cold in here too. So my name's Chris Keary. I'm a child, adolescent, and adult psychiatrist. For those of you who haven't met, it's nice to meet you. I am the behavioral director at the Angelman Syndrome Clinic at Mass General Hospital, where I see kids, teens, adults with Angelman syndrome for a behavioral consultation or for ongoing care. And I'm here to talk to you a little bit about some of the work that I've done with kids, teens, and adults with Angelman, kind of how I approach a behavioral evaluation, some of the main areas that I think about when I'm assessing behaviors. And I kind of propose a little bit of how I think about it. I'm also going to tell you a little bit about the results of a study that we did over about 2 years. I see some familiar faces in the audience. Some of you may have participated in this study, where we looked at anxiety, primarily anxiety and other behavioral issues in Angelman syndrome, and I'm going to present some of the results. The study was funded by the ASF, so which means it was funded by you all, essentially, and thank you for your participation in helping to fund the study. And so I'm going to be presenting some of the results here today, or some of the take-homes from the initial findings. And we'll try to leave some time for questions as well. And if I haven't met you, please come up and introduce yourself. I'd love to meet you in person. So let's get started. So again, the talk outline. I'm going to first describe the study that we did, looking at anxiety and Angelman syndrome and other behavioral issues, what we measured and how we measured it, in order to understand some of the results. I'm going to propose a couple of particularly important areas to assess for behavioral issues in Angelman syndrome and how that's based on previous research and some of our findings in our study. We're going to talk about particular cases, which are kind of examples of presentation concerns of some of the families I've seen, and we're going to leave some time for questions. These are my disclosures over the past 5 years. You'll see the sources of research funding and some consultation work that I've done. But I won't be talking about any treatment today that has anything to do with any of these disclosures. Also, part of what we're talking about today will be medications. All the medications I'll be talking about are off-label usage, which means we don't have any really studies looking at specific medications, specific in use in Angelman syndrome for behavioral reasons. So in that way, a lot of what we're talking about is off-label. Also, I'm not selling or promoting any commercial related items today. Okay, so the anxiety and Angelman syndrome study. It was a 2-year study where we recruited individuals, kids, teens, and adults with Angelman syndrome with a wide variety of different ages and molecular inheritance types, and assessed for a wide variety of different behaviors. I was recruiting at the conference in Phoenix. Some of you may have participated there. We had participants from our Angelman Syndrome Clinic at Mass General, and then 20 families who were willing to donate some of their time in Phoenix for us to spend some time with them. Our visits with participants were in person with a kid, teen, or adult with Angelman syndrome and their caregiver, someone who knew them and loved them well. And for that reason, it was right up front that we were interested in studying anxiety. So we ended up with a participation group that perhaps was more enriched for behavioral issues. That's kind of how we wanted it in some ways, because we wanted to really know when there are behavioral issues, how do they look in Angelman syndrome. So that limits some of our ability to say, okay, here's the exact prevalence of these particular issues in Angelman syndrome, but it really is good for us in terms of saying, here's how it can look, which was our major goal, one of our major goals for the study. We asked about anxiety in 2 different ways. One, we used some standardized assessment tools. These are like questionnaires that have been used in patient populations, kids, teens, and adults who have a developmental disability of some kind or another. Then we also asked parents and caregivers in their words, what were the behaviors they saw that made them concerned about anxiety, so that families could describe it themselves. And then we asked some other assessment tools as well, which we'll get into. That was the design. So I want to talk for a moment about the interviews that we did with families, which I see as being some of the most important data to come from this study. We asked 3 questions. One was, do you think your loved one with Angelman syndrome has anxiety? And what were the behaviors you saw that made you think they're experiencing anxiety? And in what situations do you see those behaviors? We wanted to ask these questions in a way that didn't necessarily ask people to measure the severity of anxiety per se. We really wanted to hear about specific behaviors. The idea being is then we could take that information and we could give it to clinicians, caregivers, and other families to specifically describe behavior. If the idea being that this would be a good way to measure it in the future, where you can ask specifically, do you have these behaviors? Do you see it in these situations? And there'd be less situations where clinicians were asked to make a judgment call on something difficult, knowing what the emotional experience might be like for someone with Angelman syndrome, especially if that clinician doesn't know the angel really well. You know, can they use specific behavior? We then took all that information we came from parents, we coded it, and then we looked at prevalence rates of specific areas of what families described. So here are some takes from families. So we had some families come in and we asked, does your loved one with Angelman syndrome have anxiety? And they said, I was hoping you would tell me the answer to that question, which surprised us, but I suppose maybe it shouldn't. Some families were describing total certainty that their loved one had anxiety. And some families were describing the same behavior and saying, I'm not entirely sure if this is anxiety. Help me kind of piece out, you know, what may be anxiety, what may be other issues. So that was an important take home for us, that a lot of families are looking for some help. You know, clinicians need to listen to families, but families are also looking for some help from clinicians saying, does this look like the anxiety that you see in your other families that you care for? So that's an important part of this research. Behaviors described by families ran the gamut of different behaviors, some of which sounded clearly like anxiety, and some of which sounded a little bit like other behavioral issues. Like, for instance, 11% of families reported hyperactivity, actually is their major concern that they described as anxiety. Some families described boredom as a trigger, or having to wait as a trigger, which may represent anxiety, but might not be anxiety necessarily. It's not like a specific anxiety-provoking demand might have been put in place. So that made us wonder, are families describing some actually other emotional states, some other issues that may not necessarily represent anxiety? Why is it important to try and distinguish anxiety from other behavioral issues like hyperactivity or like problems with frustration tolerance or anger management? Why is that important? Why do we want to distinguish? I think it's very important. And the reasons why I think it's very important, first of all, is that, like I said, families are oftentimes maybe coming to us with asking for some guidance. Do you think they may be experiencing anxiety? Can you help me sort of piece this out? So families want that, I think, from clinicians, or many families do. Also, it's very hard for us to develop standardized treatments for specific behavioral issues if we're lumping all behavior into one category. And I think that's how it was for maybe a long time, that behavioral issues may be all lumped into one category. And so you go to one clinician, they recommend one treatment. A different clinician, they're recommending a totally different treatment. I think that's probably got to be maybe somewhat maddening for families, that it's so different. And it's hard to develop a real standard of, okay, if we're seeing these behaviors, this is kind of the first steps of things to consider. That's what I'm hoping the future will hold for sort of treatment or recommendations for behavioral issues in Angelman. So I think it's real important to distinguish, and that's part of the purpose of the study, and it's based on the research I'm going to describe today. So I'm going to propose 3 different domains of assessment. Anxiety, hyperactivity, which are pretty self-explanatory, and irritability, which is maybe a little less self-explanatory. Irritability is a term, or sort of a term taken from a research world in terms of other individuals with other developmental disabilities. And it is how it's described. It's really problems with handling frustration and anger. I sometimes use the term anger management, kind of, or major intense angry moods, kind of as interchangeable for this, and I'll use those terms interchangeable. I think about that as being a different thing than anxiety, problems with intense frustration or intense anger. And I'll describe a little bit about how that's different in a moment. But I'm going to propose these as being kind of three different domains. And this is oftentimes when I'm doing a behavioral evaluation, I'm listening for issues in these major categories. So what we're going to do is we're going to go through each of the categories here. We're going to present a case of what might be a prototypical example of the patients I see. We're going to talk a little bit about what's the research for that being an issue in Angelman syndrome, and then our findings from the study, and then we're going to talk about what a treatment plan might look like with that particular issue. And then we're going to talk about the real world, which is that you sometimes see all three together. Okay. So let's start with talking about anxiety. The first case I want to talk to you about is a 26-year-old man with Angelman syndrome, co-occurring seizure disorder, and constipation were the co-occurring medical issues. And parents came with a real concern about anxiety being the issue. They described the behaviors of worried emotion, worried look on their face, sweating, loud shouting or vocalizations, forceful grabbing and pulling of hair, and repetitive gagging. Gagging that went on for minutes, 10 minutes, 15 minutes, 20 minutes at a time, repetitive gagging. And so initially families understandably thought this was explained by gastroenterology issue like reflux. All that workup came back negative. Treatments for reflux didn't seem to help. And the behaviors seemed to occur primarily in the context of separation from a parent, separation from a loved one, or a situation where they entered into crowds. Those were some of the things that originally made the family think, okay, maybe this is anxiety. So there's a really sort of classic presentation. So let's step out here and talk about what's the previous evidence for anxiety being an issue. There's really a growing literature basis for this, but it was first described back in 2001 by Dr. Clayton Smith, who in a very important study described in parents' reports anxiety being a concern. There was a study in 2005 and 2009 looking at large populations of kids, teens, and adults with Angelman, which showed really significant behavioral problems with a change in routine or aversion to noise, things that we might think might be anxiety-provoking. And then a study in 2015 looking at adults showing a large percentage of caregivers identifying signs of anxiety in their loved one. Interestingly, the coinciding of anxiety being an increasing concern in a lot of literature coincides with studying more teenagers and adults with Angelman syndrome. We'll come back to that in a moment about how that might be driving the increased understanding or recognition. So I'm going to tell you about some data right now. I'm going to let you know what were the behaviors that parents described, that caregivers described that made them concerned for anxiety, and what was the prevalence for them. We were very interested in, if possible, seeing if we could distinguish anxiety from those other behavioral issues I was talking about, hyperactivity and anger management. And the ways we were trying to see if we could distinguish with that is we had these other assessment tools, the Aberrant Behavioral Checklist, what's kind of listed right here. That's an assessment tool that's used a lot in kids, teens, and adults who are in a study who have a developmental disability of some kind. So we look to see, do the reports, the behaviors described by parents and the situations that it happens in, do those correlate with measures of irritability or anger management? Do they correlate with measures of hyperactivity, or are they completely uncorrelated, suggesting what might be kind of maybe pure anxiety, separate from other behavioral issues? Does that make sense, how we were kind of thinking about it? We really wanted to see, are there certain questions that we can ask that seem like really maybe clearly anxiety rather than other behavioral issues? And then we had these three assessment tools that we did. I'll describe some of the research here. The ADAMS, the PARS, and the CASI, which are all questionnaires for asking anxiety in developmental disabled populations. So here are the behaviors described by parents and caregivers. The writing maybe is a little bit small from where you can see from there, so I'll go through and describe each of them here. Aggression was the one that was far and away the most commonly reported by families. Over 70% of participants in the study identified that as the behavior that made them concerned about anxiety. Loud vocalizations were coming in close to 40%. Fearfulness, property destruction, crying, gagging and vomiting, close to 30% of families described that as the behavior they were concerned for anxiety. Self-injury. Those were all the above 20% frequency. And then the between 10 and 20% frequency, flopping, that's sort of throwing yourself to the ground. Agitation, whole stiffening of the body, sweating and avoidance, seeking physical reassurance, tremor, and hyperactivity. We asked in follow-ups, did it ever seem like these behaviors of tremor or stiffening were related to neurologic issues? We sort of asked that in follow-up, and that was something that was considered. The families didn't think so. We don't know for sure. We can't rule that out. But that was what the parents described. So now what I'm going to do is, at the next slide, we're going to gray out the behaviors that correlated in a mild, moderate, or severe way with measures of anger management, problems with anger management, or measures of hyperactivity. So the behaviors that seemed to be more clearly perhaps just anxiety were fearfulness, crying, gagging and vomiting, flopping to the ground, stiffening, avoidance, seeking physical reassurance, and tremor. These were the behaviors that perhaps we might think might be more pure anxiety, at least in this population, this group of 50 individuals with Angelman syndrome, kids, teens, and adults. Now, one thing I really want to make sure I bring across to you all is you might say, well, does that mean aggression does not represent anxiety? I don't think that's necessarily what this research suggests. And here's the reason why I think that. What we found in this study is that the participants that had the most severe behavioral issues had symptoms in all three of those categories I told you about. So that really affects in a lot of ways our ability to say, okay, this is definitely not aggression, because it may suggest actually that the presence of aggression really represents severe anxiety. It highlights a challenge in studying emotions in kids, teens, and adults with Angelman, which is that there's oftentimes combinations of all three of the categories that I'm telling you about, particularly in individuals who have the most severe behaviors. So what I would say from this is, this is my take home from the findings here. If I'm seeing an individual with Angelman and the families are telling me they're seeing aggression, that doesn't rule out anxiety in my mind, but it also isn't maybe a slam dunk that it's necessarily anxiety. I'm asking these additional questions to help make me feel more confident in knowing it might be anxiety. Does that make sense? How I'm kind of thinking about it? And in some situations, we really will not be able to say necessarily, okay, I'm 100% sure. And we'll get about how to approach those situations. But I think these questions are really, these particular categories that are not grayed out, I think are really helpful, because they're questions that clinicians and families can ask themselves, and they seem to be really more convincing for anxiety as described by maybe an anxiety that's specific to kids, teens, and adults with Angelman. Let's look at the triggers for behaviors. So far and away, the most common one was separation, and this will probably come as very little surprise to many of the people in the audience, right? Separation was the most common thing, coming in at over 50%, as the trigger, we could say the stressor, that led to the behaviors concerning for anxiety. Crowds was the next one, coming in at over 40%. New places, coming in around 33% of families. Changes in routine at 30%, and unfamiliar people at 20% is the most common triggers. Then in the 10 to 20% frequency, some individuals had more classic phobias, what we might think about as phobias, like fears of insects or fears of dogs, fears of animals, coming in at close to 15%. Loud noises, intrusion on personal space. Someone who comes into someone's space without maybe introducing themselves or taking their time and getting to know them better. Medical appointments. Transitions, uncertainty, and limit setting were the most common things that were described by families. So let's do our same thing here, where we gray out the ones that are correlated with measures of frustration, tolerance, and hyperactivity. The ones that seem to be more clearly perhaps pure anxiety: crowds, fear of new places, fears of unfamiliar people, animals, insects, intrusions on personal space, medical appointments, transitions, uncertainty, and limit setting. Now again, does this mean that separation, upset with separation, is not anxiety? Well, not necessarily. But it means that in our patient population that we were studying, the subjects who wanted to participate, those who had problems with separation oftentimes also maybe had problems with anger management or hyperactivity in this particular patient population. So again, I think the questions of, are we seeing anxiety related to these other behaviors, helps you know really for sure, okay, I'm pretty sure this is how anxiety might look in kids, teens, and adults with Angelman syndrome. But I I still think there's plenty of reason to be concerned that separation really is a major source of anxiety in kids, teens, and adults with Angelman. So I want to make sure that still comes across. This really overlaps with what other research is showing and suggesting regarding what are behaviors or triggers for anxiety in kids, teens, and adults with Angelman. This is a study that was published just a couple months ago by a group in UNC, Dr. Wheeler's group, a really important study here that found that what they did is they developed an assessment tool measuring anxiety in parents' own words. That parents themselves figured out. It was a tool that was developed by the clinicians, and parents could fill out the results themselves. And they had 100 participants with caregivers of Angelman syndrome fill this out, which is sort of terrifically high numbers. And they found extremely high rates of separation, distress with separation, among almost close to 80% of teenagers with Angelman. And then other common behaviors concerning for anxiety being really clingy, being not able to relax, trembling, or nervous habits. Other important findings from this study that are worth bringing out. They found the numbers really were higher in terms of anxiety behaviors in the teenage and adult years as compared to before teenage years. They also found higher rates in kids, teens, and adults with Angelman who are in non-deletion type as compared to deletion. We'll talk a little bit more about that in a moment, but a really important study that just came out recently. Now, how about those specific anxiety assessment tools that I told you about? I mentioned the ADAMS, the PARS, the CASI. These are assessment tools that are used to measure anxiety in kids, teens, and adults with developmental disability. Well, we found that the tool that you used mattered a lot, and there was really significant differences in terms of the score depending on the tool you used, which is kind of a concern because it suggests that we may need tools specific for kids, teens, and adults with Angelman. For instance, the ADAMS, which is currently the most commonly used measure of anxiety in previous studies of anxiety in Angelman, had scores, I don't know, you might be able to see from here, it says 7.2, and there's a mean max score of 21 that you can get on this assessment score. So that means the mean was around about as third high as you can go on it. You'll see this little line here. This line refers to the cutoff point for what's proposed to be highly correlated with anxiety disorders. So the take-home from this is that scores seemed relatively low using the ADAMS, but they scored above the cutoff point for the mean using this other assessment tool, the PARS. So it mattered which assessment tool you used. People scored higher on this other assessment tool. And we theorize this may be because ADAMS doesn't ask about separation anxiety symptoms. So that's a real problem with some of the research that's been done so far. We have an assessment tool we've been using that asks nothing about separation. So I think this highlights there being a need for assessment tools specific for kids, teens, and adults with Angelman syndrome. The PARS perhaps is better, but the PARS requires that individuals be able to have some verbal, expressive language abilities in order to get a really good sense. So the PARS has problems with it too. Did anxiety differ by gender and age? We didn't find any differences by gender. We didn't find any differences by age. But as I mentioned, that study by the UNC group did. There was also a recent study by Prasad et al., which I've described down here, which was a retrospective chart review of a large number of individuals with Angelman, kids, teens, and adults, that found higher rates of anxiety in the 15 to 26-year-old and then 26 and above population. So really the evolving data suggests higher rates of concerns in Angelman syndrome in the teens to adults category as compared to the preteens. We also found, before I mention that piece, so one thing we did find that matters by age. A different assessment tool we did was something called the CASI. CASI is a nice assessment tool because it allows you to specifically look at separation anxiety symptoms. It's got specific domains for asking about separation problems or anxiety with separation. And what we found was there were definitely individuals in our study that had separation anxiety problems specifically, and that those levels were high even in the 13 to 17-year-old age group, perhaps even a little bit higher than the 12 and below age group, and were even present in the adult age group. This is not what we would expect as compared to other populations with a developmental delay of some kind. It's not what we'd expect in terms of studies of neurotypical individuals who would expect to have separation anxiety really go down as they get older. Separation problems persist into adulthood, is what our study found. We also found a difference in anxiety levels in individuals with deletion positive form of molecular inheritance as compared to non-deletion positive. Higher rates using the specific score, the CASI, and then maybe a little bit higher in separation anxiety as well, and also found a little bit of a difference in the PARS. However, I would really caution you from walking out of here saying, this is not destiny, necessarily. There were some individuals with deletion positive form that did have relatively high scores in terms of anxiety. And there were individuals with the non-deletion positive type where you can imagine here's an error bar. It goes down in the other direction too. So there were other individuals who scored really down low. So this difference in deletion versus non-deletion, it's present if you look at populations in a large way, but person to person, there's still a lot of variation. So you really can't know 100% for sure based on the molecular inheritance type what it will be, but the chances are a little bit higher, it looks like, at least in this patient population, for levels of anxiety and non-deletion positive. Does that make sense? Okay. Yep. So let's come back to treatment. I'll first talk about non-medication treatments because I think that's really where treatment should be. And ideally and hopefully for most individuals, that's where it will stay. And medications won't need to be a part of the treatment. But we're going to talk about both today. Anxiety treatment approach, some of the things I think about when I've got concerns about anxiety is I'm really wondering and asking about what are some of the efforts that have been put in place to develop functional communication strategies. If we think that one of the major triggers was an unexpected change in routine, then visual schedules and ways of conveying what the routine is going to be become very important, particularly if that's the trigger. I'm asking about things like what's the routine that's used to convey what the schedule is? And if there's a change in the schedule, is there a way to sort of communicate that in advance through things like social stories that may help prepare people for a sudden change in routine or new individuals or doctor's appointments? Do doctors' offices have ways to communicate to families what an appointment will look like in advance so they can prepare the family and the individual? Here's what we'll do first. First, we'll sit in the waiting room. Then we'll move to checking vital signs. Then we'll move to this step in terms of the physical exam. Those things may be really impactful and helpful for kids, teens, and adults with Angelman. Occupational therapy is something that I really ask about as well. If we think about stiffening or trembling as being things that might be behaviors concerning for anxiety, it makes me think about calming strategies calming sensory strategies that may be helpful for individuals, kids, teens, and adults with Angelman. Things like, for instance, weighted blankets. I put here behavioral therapies because if you think about what the treatment would be for an individual with separation anxiety, the treatment would be a little bit of exposure gradually to the thing you find scary. Same thing with most anxieties. If you do a little bit of the thing you find scary, like giving a presentation in front of a bunch of people, if you do it and you do it more and more and more, you get more comfortable with it, you get more relaxed with it, it becomes less of a concern. And so the question is, would this make it easier for kids, teens, and adults with Angelman, around separation, for instance, or around a crowded situation or a doctor's appointment? Can we think about developing a graduated exposure to the thing that's scary to make it easier? For an example, for separation, it may be a separation from a beloved caregiver that takes place just for 10 seconds, then for a minute, then for 5 minutes, where with big reinforcement and positive, you did great at the end of that. There's not a lot of research looking at whether that's an effective treatment, but I think hopefully that will be a direction for the future of something to try, because that's the treatment for a phobia of some kind, like separation anxiety or fearfulness. And sometimes I'll bring that up as things to try. Who helps develop a plan like that? An applied behavioral that's a plan that could be part of an ABA treatment, applied behavioral analysis. Sometimes ABA can be hard to get covered, though. It's also a treatment that a cognitive behavioral therapist might put together, particularly people have heard of CBT, cognitive behavioral therapy, particularly a clinician who practices CBT that has some experience working with kids, teens, and adults who have a developmental delay of some kind. Exposure therapies are the bread and butter for a lot of CBT therapists. For instance, things like phobia of flying on planes or spider phobias or things like that. So what I discuss a lot with families if they can't get ABA covered is to see whether or not they can find a cognitive behavioral therapist who might help them construct a plan like this and see if it can be effective. Those are some anxiety treatment approaches. In terms of medications, assuming that those things aren't helpful, Buspirone is oftentimes a place that I might start when it comes to treatment for anxiety. It has effects on serotonin. It's generally tolerated very well, giving it a natural sort of place to start. Stomach upset, dizziness, sedation, and in rare cases, increased irritability are side effects to watch for with this medication. But for most individuals with Angelman syndrome, I've not seen side effects with this medication. And it tends to be tolerated well. Benzodiazepines, which you've heard a lot already today if you've attended some of the other sessions, which have effects on GABA, gamma-aminobutyric acid. Side effects here to watch for: sedation, fatigue, dizziness, ataxia. Ataxia is a staggering gait, so a worsening in gait. Paradoxical reactions, which is rather than it being calming, all of a sudden individuals are silly, giddy, goofy, almost drunk appearing, more agitated related to it, a rare side effect that can be seen with benzodiazepines. This gets used a lot because benzodiazepines are also treatment for seizure disorders. Antidepressants, a typical treatment for anxiety in kids would be a use of an antidepressant medication such as Prozac or Celexa, citalopram, Celexa, Zoloft. So serotonin or norepinephrine reuptake inhibitors. Side effects here are probably a little bit more significant, can include things like nausea, diarrhea, can include headaches or sweating, things that would be hard for an individual to convey if they were having these symptoms. So, when these medications, if I'm thinking about them, we're talking about a really slow and low and moving very slowly and carefully with this medication. You can see the same effects if you're coming off of SSRI medications, making it a really good idea to really go slow if you're trying to come off these medications in order to have it be successful. And propranolol, down here at the bottom, this is a beta blocker medication. It's used for blood pressure control, so that's a side effect that needs to be watched for. But it's also a common treatment for anxiety for people who have performance anxiety, like a concert pianist who has anxiety performing in front of other people might take a dosage of propranolol before they go on stage. So it's a reasonable thing to consider. Things to watch for here: tiredness related to this medication. And it needs to be avoided in individuals who have asthma or heart failure. We published a study just that came out a couple months ago of describing 3 individuals who had improvement in behaviors concerning for anxiety with Buspirone. They had a reduction in self-injurious behavior, aggression, resolved sweating, decreased fear of crowds, and reduced excessive swallowing and vomiting. Those were taken in whole, 3 individuals who were taking Buspirone. And it's the first treatment report of a medication to address anxiety and Angelman syndrome. And we need more of these kind of studies. Clinicians who are caring for individuals with Angelman syndrome and trying things, putting out their research and saying, we tried this, it helped some, because that's where you start in terms of then developing other treatment studies. Okay, let's move on to talking about hyperactivity. So anxiety, kind of the majority of our talk. We'll move a little bit more quickly through these other domains. Hyperactivity. The case here, a 9-year-old boy with Angelman, gastroesophageal reflux, epilepsy, and the main concern was a constant need to be in movement. Sitting for a prolonged period of time, was not going to happen. Really, even for longer than 5 seconds was impossible. This really got in the way of making progress in terms of therapies, because it was really hard to stay on one particular therapy for anything longer than a couple seconds. They needed to take constant movement breaks, which maybe slowed down some of the progress with their therapies. They had these giddy episodes, or sort of laughing, silly, giddy episodes, where they could be destructive or just certainly disruptive. Not really angry, but there was going to be no focusing on learning when those things happened until it passed, essentially. So is there evidence for hyperactivity being an issue in Angelman syndrome? Absolutely. Studies going back to 2000, a study by Clark and Marson, 72 individuals, they found very high levels of hyperactivity. And a study in 2004 of almost 100 individuals with Angelman syndrome, also higher rates of hyperactivity as compared to individuals of other developmental disabilities. Our study also found elevations in hyperactivity. Again, this is using that measure I told you about, the Aberrant Behavioral Checklist, the ABC Hyperactivity Subscale. This here shows, a average score of 20. It's pretty comparable for males as compared to females, so females are not necessarily spared from the issue of hyperactivity. And these numbers really go much higher than other measures of kids who have a developmental disability of some kind or another. So the rates are certainly higher in Angelman. We broke it down by age, and we looked at 12 and under, 13 to 17, and over 18. And what we found was it definitely seems to be decreased incidence, at least in our patient population, as people get older. In older groups, there were lower rates of hyperactivity. But they never got so low that they were below as compared to other developmental disabilities population. So my take home from this piece was that hyperactivity, unlike anxiety, seems to potentially decrease with age, but there were some adults who still struggled with major problems with hyperactivity. Are we breaking it down by genetic subtype? We also found higher rates of hyperactivity, just mildly higher, in the non-deletion positive as compared to deletion positive, although they come pretty close to one another. 19.5 was the mean here in 24. So how about a hyperactivity treatment approach? What might that look like? It's not necessarily easy to say for sure whether this is ADHD, whether we would call it exactly ADHD. It's oftentimes hard to assess what really inattentive challenges might look like or be comparable for kids, teens, and adults with Angelman. But kids with ADHD certainly will have an improvement in attention with regular exercise and sleep. And what I've heard from a lot of families have told me is that after like a really intense time in the pool, for instance, or a really good physical therapy session, there's sort of a calmer body after that time period, that physical activity may really help with this issue of hyperactivity. The sense of there being a lot of energy to burn off, basically. Educational interventions, regular movement breaks, thinking about minimizing distractions. The most common distraction, absolutely, that I hear from families is preferred peers, peer groups, people. I think about there being really a strong love or interest in other people, and boy, can that be distracting. I think we need to find that balance between encouraging participation and inclusion with peers in school. I think that's really important for a lot of kids, teens with Angelman, but also perhaps maybe during the most important therapies, it's helpful for it to be one-on-one to help with focus. And also making sure schools are aware of the elopement and fall risk in families who have significant hyperactivity, kids who have significant hyperactivity. There's a real risk there, particularly if people who still have challenges in their motor function that, really in the school or in day programs, they really need to be closely thinking about this issue of the fall risk. Occupational therapy interventions, I see a really common coinciding of repetitive chewing, fidgeting, mouthing in kids who have a lot of hyperactive behaviors, making me think about perhaps calming sensory interventions, chewy tubes, things like that, and that perhaps addressing hyperactivity may also help address some of these intense sensory-seeking behaviors. What's a treatment approach here from medications-wise? A common place to start is a medicine called guanfacine or Tenex. This medicine is an alpha agonist medication. It can also have effects on blood pressure, but it's a standard treatment for hyperactivity in really young kids. It tends to be tolerated much better than stimulant medications like Ritalin, Focalin, Adderall, those classes of medications. These tend to be tolerated better. You can sometimes see some tiredness. You can sometimes see worsening of constipation, which is a really important thing to think about because there might already be a real existing problem there. Stimulant medications, I don't have a lot of experience in using these medications in kids, teens, and adults with Angelman because I'm a little bit concerned around the potential for decreased appetite, the potential for increased irritability, which you can see with stimulants. You can sometimes see worsening sleep, already a major concern in a lot of the kids I work with. I usually don't start with thinking about a stimulant medication, much more likely to be thinking about this if we're at the point of talking about medications. And there's a medicine called atomoxetine or Strattera, if you've heard of it, which can be really effective for hyperactivity. Not a lot of experience or seen it being used in kids, teens, and adults with Angelman, but it certainly is an option or something we're thinking about. Side effects to watch for here, it too can decrease appetite, can cause fatigue, can cause constipation, GI complaints, constipation and insomnia. Changes in blood pressure more rare with this medication, or in some cases increased irritability. All right, let's move on to finishing up talking about irritability. Again, irritability, what am I talking about here? Irritability, again, problems with anger management, intense expressions of frustration. Example here, 16-year-old girl with Angelman syndrome, constipation, intermittent myoclonus, the medical history. And the main concern was aggression towards parents that seemed to occur whenever there was a limit setting or a demand. And it wasn't a brief hit and it was done. It was part of a larger, intense emotional meltdown that went on for really 15 minutes at a time, which is a long time to be going through a meltdown. It didn't seem to get better when giving the person or the girl what she wanted. It persisted for a while. The mood just had to pass on its own. And there was persistently grouchy mood in between those tantrum episodes. And that really made community trips almost impossible because there was no sense of when it would suddenly come on with any small little demand or frustration. Irritability. So is there evidence for elevation in Angelman syndrome? Well, there's evidence for rates of aggressive behaviors. There was a study in 2010 that found elevation. I told you about a lot of parents, over 70 parents reporting aggressive behaviors. And then there was a study that found elevations in irritability in 12 subjects. However, the data here is a little bit more mixed. There was a large study of 73 individuals that did not find elevations in terms of irritability. Is it possible irritability is overestimated in kids, teens, and adults with Angelman syndrome? I wonder if that's a real concern. Clinicians may hear that aggressive behaviors are taking place and assume this is irritability, when the aggression might be more a hair pull when someone's really excited or delighted at social interaction. I worry that some clinicians might move to thinking about treatments for irritability with aggressive behaviors, which may not be the parent's main concern. When I started working with kids, teens, and adults with Angelman, I heard about aggressive behaviors, and many parents where that was not necessarily their main concern. Their concern was other things, which surprised me. And so I think about that as being different than irritability, where there's an intense emotional meltdown with aggression as a part of it. So I worry about it being overestimated. So here's how I think about it. Aggression doesn't necessarily lead me to think about irritability. I might think about anxiety if the triggers are a fearful stimuli of some kind. If people's mood between the aggressive episodes is their normal self. The mood is pretty good between those episodes. If the episodes of aggression are quick, over quickly, they pass when the scary stimulus is removed. They pass quickly. And the senses of parents kind of trying to avoid the scary stimuli. Well, I think more irritability when the triggers are more broadly non-preferred demands. There's maybe a persistent negative or grouchy mood between those episodes. A sense that moods are these storms that need to they'll come and they'll pass. They may last really a long period. And the feel with the families, it's much more that the families are walking on eggshells around any little small demand that may come up. That's the more of the sense. This is some of how I think about trying to distinguish between the two. Does that make sense? Irritability and Angelman syndrome. So what did we find in our study? Our levels were not particularly elevated. They look higher here compared to other developmentally disabled populations, but we had a mean of 12 out of a max score of 45. That's kind of in the 1/4, the lower 1/4. That's where the mean was. There were certainly individuals who did score high, who participated in our study, but these numbers didn't look as high to me as some of the numbers in terms of anxiety or some of the numbers in terms of hyperactivity. Did they differ by age or subtype? We did see some increase in non-deletion positive as compared to deletion positive. And we didn't find any differences by age. So think about treatments here, So I think a lot about what are functional communication strategies to express frustration. Are there strategies, communication strategies to ask for breaks or ask for things that individuals want? Think about all the things that we do to manage frustration. They're oftentimes so much based on verbal abilities. And so I think it's a real challenge for a lot of kids, teens, and adults with Angelman. Can functional strategies around expressing frustration or asking to take a break be part of a communication strategy? Behavioral therapy can really be helpful here. First of all, they can identify the parts of aggression that may be really more attention-seeking, that can be addressed more with behavioral therapy, that really may not actually be irritability as we're understanding it. They can be really helpful for tracking a response to a treatment of some kind or a medication. You have to watch. Sometimes the behavioral therapy can make things worse, but then can make things better after that, as the behavior might be escalated, but then before it then is extinguished and goes down. So that's a plug to maybe not give up immediately. You have to really think about making sure you're not missing medical contributors. That's been talked about by a number of of the speakers so far. If people are persistently grouchy, it could be that they're in pain. and considering the possibility that you're missing depression. And I'm listening for things like a loss of interest in preferred activities, much less interested in leaving their room or other people as much as they used to. That's a lot of what I'm listening for there. How about medication treatments? Well, a mild place to start are, I put here alpha agonists. That's that guanfacine medication I told you about. The other name for that is Tenex. Or beta blockers. That's the propranolol medication that I told you about. Oftentimes, these medications down here have mood stabilizing qualities, but carry more in the way of side effects. So I'm oftentimes thinking about, can I start with a milder approach if I think it's related to irritability? And in situations here, I'll often start with medicine that is anti-seizure medication before I think about other medicines that carry more side effects. Topiramate, clobazam, which is Onfi, gabapentin, which is Neurontin, lamotrigine, which is Lamictal, all in my experience have had oftentimes some benefit in terms of controlling intensity of mood changes. So those are things I'll think about. In other developmental disability populations, carbamazepine and valproic acid can be helpful, but we've learned from another speaker today that can really worsen motor function or worsen seizures, so I try to stay away from those treatments. Atypical antipsychotic medications, I don't use this a lot. It may be things that you think about only in the most severe of situations where the effect on life is so impactful. Behavioral treatments and other medications don't seem to help. But there are major concerns with using these medications in kids, teens, and adults with Angelman. Concerns about increased appetite, obesity, already an issue in Angelman. Oversedation. I think about medications that cause oversedation can really cause regression in motor skills or skills that are learned. Or constipation, already a concern. These medications can make those worse. And I think individuals with Angelman syndrome are more sensitive to these medications in terms of developing higher muscle tone or tremor or kind of Parkinson-like symptoms, which these medications typically cause at high dosages. They cause at lower dosages in Angelman syndrome in my experience, making me really shy with the usage of these medications. One in that class, quetiapine, is much less likely to cause these side effects and maybe what I would think about first if I am thinking about these medications. Okay, so in closing, this is kind of, in my experience, what the real world looks like. More than clearly distinguishing between the two. Sometimes you clearly distinguish, it's one, but this is, particularly in more severe behaviorals, this is more commonly what I'm seeing. So what does this mean for treaters? I think what this means is you try to start with the treatments that may be helpful for anxiety that carry less risks before you're moving towards treatments that are more along the lines of irritability that carry more risks. I'm hoping the increased recognition of anxiety as an issue in Angelman syndrome will lead to less prescribing of those higher risk medications that I told you about. People will be thinking more about treatments for anxiety before they move to medications like Risperdal. And I'm hoping that that will be a beneficial side effect to thinking about anxiety. And another important thing to bring up is a note on sleep. Effective treatment in sleep I've seen improve some of these behaviors when sleep is better controlled. Oftentimes that's a place to start in terms of a behavioral treatment, trying to get sleep, if possible, better under control. In some cases, that's made behavior during the day better. In some cases, it hasn't. Commonly used sleep medications in the population we looked at were melatonin, clonidine, and trazodone, and there was some good evidence for tolerability with all three of those medications. I'm just going to leave you with this last case. This is a 24-year-old woman that we saw with Angelman syndrome, constipation, and epilepsy. They're presenting concern, very high energy, very destructive behavior, sort of a destructive curiosity, getting into everything, breaking everything down. Daily agitated episodes, like that irritability I was talking about, intense emotional storms with self-biting and aggression, and impaired sleep. The treatment plan here included adequate treatment of the seizures with less sedating medications, improved sustained sleep through the night with medications. It wasn't perfect, but it was better than when it first started. The use of oral contraceptives to suppress menstrual cycle, and adequate treatment of constipation with diet change and over-the-counter medications. Between these four interventions, this individual successfully tapered off all behavioral medications. This really highlights that clinicians need to be thinking about medical comorbidities before they're jumping towards thinking about a treatment, like a behavioral treatment. Really making sure they've exonerated these or thought about them as a potential cause of the behavioral concern. And in my experience, these are some of the top four, along with dental issues. Okay. In summary, the behavioral assessment of Angelman syndrome should include thinking about domains of anxiety, irritability, hyperactivity, and sleep. Effective treatment plans should take into account co-occurring medical comorbidities. Aspects of a behavioral treatment plan may include behavioral therapy, communication strategies, occupational physical therapy, and then at a last resort, medications. Future steps should include standardized assessment tools for kids, teens, and adults with Angelman syndrome to get a better sense of what we're treating, which can then guide us towards developing studies that will be effective. I have citation. Thank you. I'll take questions now. Yeah. Yeah.
Obviously, we've seen a big spike in aggression, a lot of pushing. You know, before a period, there was a lot of self-injurious behavior, a lot of biting, a lot of pulling her shirts apart, you know, biting herself, leaving like bruises, you know, hitting us, being more aggressive. So he actually, and also besides that, like sometimes my husband and I, you know, might be in like a crowded parking lot. There were certain situations where we would describe it as an anxiety episode where we'd be in a crowded parking lot in LA trying to fight for that parking spot, and then my daughter, with her voices rise, started violently banging her head against the car wall and stuff. And so he actually prescribed Zoloft, and he started at 225 milligram pills once a day. And we started to just see, and in the morning she, you know, could have been just because she's irritable about waking up. We have a lot more behavior in the morning before school. But once we started from the Zoloft, she was so, like, chill.
That's great.
But my question is, we went into a follow-up appointment recently, and she just got really aggressive in the appointment. You know, like, my hair was supposed to be longer. I mean, I didn't cut it for her.
I have heard that from families who do cut it.
But she, you know, he just saw her like grab my hair and, you know, do stuff, and you know, he did everything you shouldn't probably do, like don't do that, you know, like making it worse for us.
Yeah,
but, so he just thought, like after seeing some spikes while we're in the office, he decided to up the Zoloft to 100 milligrams. Is that a large dose, or is that an okay dose?
Yeah, would you be comfortable sharing the age of your daughter? 14. You might have told me that at the beginning. Yeah, I think my sense is it's not an unreasonable dosage of the medication for a teenager. We don't really know what the right dosage may be for an individual with Angelman syndrome, but for a child of that age, a dosage of 100 milligrams is a reasonable thing to consider. The rate of dosage increase is maybe a little bit faster than I would do. I would probably go up by maybe 25 milligrams of Zoloft at a time, or even in some cases by 12 and a half of a 25 milligram tablet dosage. Okay. I might have gone a little bit slower because I always think about, okay, I'm thinking about an individual who can't tell me if they're having side effects related to it, so I'm always so careful in terms of how slow I go up. But I think the goal of getting to 100 is not an unreasonable dosage at all. Okay. Yeah. Absolutely. Yeah. Yeah, definitely. And I've seen situations where if you worsen constipation, now you've worsened all the behaviors and you've kind of made things worse rather than better. I always talk about how we got to stay really on top of bowel movements during that time. But not at all. Not at all. Absolutely. Yeah. Mm-hmm. Yeah. Yeah. Huh. Yep. Mm-hmm. Yeah, yeah, absolutely. Yeah. Yeah, it makes it a little bit tougher, right, because there's not a clear connection between separating from a loved one or a crowded situation, and it definitely occurs. Yeah. 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 I always try to make sure we thought about reflux first. Sometimes I'll refer people to a gastroenterologist at our clinic before we know for sure. They can help identify things like, for instance, evidence of pain or excessive drooling, particularly after more acidic foods, repetitive arching of the back or gorging of food really quickly. That can all be behaviors that are sometimes seen in evidence of reflux. I'm not hearing as much about that. There's also not evidence of reflux when he was younger either. Yeah. Kind of resolved. Yeah. 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 In terms of the question of whether you should treat it, it was an easy decision for some of the patients that we've worked with where the repetitive gagging was so intense and so repetitive that you couldn't break it. It went on for 10, 15 minutes at a time. That, for me, was a clear, we have to move forward with that. I am hearing a little bit about the signing all done beforehand that suggests that he may be in some distress of some kind beforehand, or there's maybe something that's upsetting. Mm-hmm. Yeah. Yeah. Mm-hmm. Yeah. 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 Uh-huh. Yeah. Yeah. One of the case report that I was telling you about, that was a similar story of one of the patients, and that improved with buspirone. If it is related to anxiety, it's possible that a medication, the treatment that's helpful for anxiety would be helpful. Another thing that is maybe worth starting is to think about behavioral, if possible, behavioral consultants to sort of track how frequent the episode happens, to look at specific causes, what's called a functional behavioral analysis of that particular behavior, to provide some outside perspective. If it is something that gets in the way, buspirone is something that's tolerable and may be worth considering. Yeah. Yeah. Hmm. Mm-hmm. Yeah. Yeah, that's a really good question. So a common place to start is a medicine that has a benzodiazepine effect, with the idea being of trying it before prime time so that you know that individuals tolerate it well, and that you're not seeing just people falling asleep related to it, because you still want them to participate and enjoy the activity and be a part in it. Okay. Yeah. Yeah, absolutely. No, definitely. A good example would be a medication like lorazepam. That's a good as-needed medication. Lorazepam, or Ativan is the other name of it, if you've heard of it, because that's something that might have its onset in, say, half an hour to 45 minutes, lasts 4 to 6 hours. Clonazepam is a medication that gets prescribed for seizures because it's longer acting. That might start working in an hour or so and then work for 8 hours, kind of on average. That's a reasonable thing to try. It's not as good as an as-needed medication because it took an hour to work and then the emotion passes by that time. But both of those are reasonable places to start. You'll sometimes see I'll sometimes consider the medication clonidine. That belongs in that alpha agonist group of medications, similar to guanfacine. It's more sedating, though. It can make it a little bit tougher to use. But it's also a reasonable place to consider. Yeah. Yeah.
So my daughter is 14, and when she was an infant, very young, she had social anxiety. It was very
Yeah. Great. Mm.
Also irritability and also the just like all the issues and very
Yeah.
complicated right now. So we're trying to
Yeah.
fill back all the layers of the onion, starting with like medical things like she got her molars and are those agitating. So we're trying to
Yeah.
figure out
Perfect.
the medical component.
Mm-hmm.
But my biggest question is in like a complex situation like that, where do I start? Because the aggression is literally so bad, she's biting herself to the point that she's bleeding.
Oh.
Her fingers are constantly swollen from the biting.
Yes.
Scars, my husband has scars all over our arms. We can't drive in the car with our own family and have other kids because
Mm-hmm.
our own family is too many people for her.
Yep.
We have a very small house, so even talking to different people is too much for her.
Yeah.
I'm just kind of wondering in
Yeah.
a complex situation, like where do I start? Because there's
Yeah.
so many issues.
Absolutely.
And pharmaceuticals don't work for me.
Mm.
She has always had very negative reactions to pharmaceuticals. So I'm kind of wondering, like, who should I seek out first? Where can I kind of start with to kind of help quickly? Because obviously I want to self-harm.
Yeah.
You know, behaviors and not
Yeah.
harming us, behaviors to die down.
Mm-hmm.
Because obviously I don't want her to constantly bleeding and bruised.
Yeah. 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 Absolutely. Yeah, the way you described it is that I think the experience of a lot of families, unfortunately more than there should be. And I think when seizures are poorly controlled, it's a little bit harder to get a picture of what may be going on that can contribute to irritability. An approach that comes to mind as you're describing it is thinking about communication with the neurologist around seizure medications that have some mood stabilizing qualities, maybe being a place to start. Mm-hmm. Okay. Oh. Mm-hmm.
They last about 3 minutes each. She's post-visual after. But then after her last seizure, she's awake for 24 hours.
Mm-hmm.
And then she gets kind of slowly back to normal sleep and normal
Yep.
baseline. So I feel like other than those breathing or like seizures that are coming, she's pretty back.
Okay.
Pretty calm and mellow,
Oh.
cuddly and
Mm-hmm.
sweet. It's more like obviously there's been but just in general,
Mm-hmm.
you know, there's triggers that are going on, but
Yeah.
all the time I feel for addressing like she doesn't like our limits, she's not getting what she wants, or there is that social anxiety piece and noise piece. And
Yeah.
like there's just so many things
Yeah, you're really in the thick of it there. Absolutely.
that need cognitive or like ABA therapy.
ABA therapy certainly comes to mind. I feel a little apprehensive recommending something that is hard for a lot of people to access. And I think a major direction of research is going to need to be to attest to how helpful this therapy can be, because I've seen it certainly be helpful. And it really helps clarify the picture in complicated situations because it can help identify, okay, what are some of the triggers? Let's try a behavioral change. What's the effect? Does it seem like there's a clear connection between the irritable periods, or does sometimes they come on out of the blue in a way that may make us think about missing some underlying medical issue? I do think ABA is absolutely something that can be helpful, and it's helpful to any clinician who's prescribing in terms of identifying what helped, what made things worse, because ideally they're taking data on all the behaviors you're talking about and can help clarify a little bit. Okay, we started the seizure medication, things got worse, let's try something else, and help clarify what are the ups and downs of irritability and what is, oh, this medicine really made things worse, which can really be hard to piece out sometimes. So I think that those things are definitely worth continuing with, really recommending. That's a really helpful thing. And every pharmaceutical under the map may have been tried, but these are some ones in terms of seizure control that have been particularly helpful for me. These may be ones that you've already tried, but I think a lot about uncontrolled seizures and ongoing irritability, trying to think two birds with one stone. In some ways, the seizures aren't as much the concern as you're describing it. And then the one other thing that comes to mind is sleep. Sometimes you can really help clarify the picture if sleep is better under control. Okay. Good. Good, thank goodness. Mm-hmm. Yeah, that's good. That's good. Okay. Good, that's the bright spot in it, yeah. Yeah. Yep, definitely. There's a question behind you here. Yeah.
My son is 32. He was an avid pacifier kid until he was about 13, and we weaned him off of it. But when that happened, he started biting his nails. And well, at first we started with stuffed animals in his bed and stuff, and then one night we found him with a lot of stuffing in his mouth, and he swallowed it with a choke.
Wow.
So now he cannot have any stuffed animals, but what he did was he transferred it to his fingernails, and so he's just got nubs on his fingers, and that's how he soothes himself. And I didn't know if there was anything that can be done about this oral fixation of Angelman kids, or if it's something, I mean, he's 32, he's been doing this his whole life.
Yeah.
I guess it's something to live with, but I didn't know if you had any comments on that.
Yeah, really good question. I think, I imagine, given what a long road it's been for you already, that you've tried about some of the behavioral interventions that might have already been tried. Things like chewery and chewy tubes. Sometimes people can really break through those chewy tubes and swallow, bite through the rubber, and then that's not really safe either. But that's probably something I imagine you've already tried. I don't love the idea of hands being covered either, because we really want to encourage the usage of the hands in a spontaneous way. One of the things I really,
I just wanted to say another problem that we've got is with him chewing on his fingers, he's now had impetigo, he's
Yep.
now had thrush, and he's also had, what's the other one? He's had 3 infections since January. So now we're taking and cleaning his hands after eating, before he goes to bed, we've got a special, to clean his hands,
yeah,
right?
yeah.
But,
Yep.
long term, I don't know what I do.
Yeah, definitely.
You can't take his fingers away from him.
Yeah. I mean, one thing you talked about in terms, well, first of all, thinking about from a behavioral standpoint, this may be something that a behavioral clinician may be able to help with, a behavioral therapist might be able to help with. The idea would be all around either substituting something in its place, or potentially trying something like a reward structure where you go for 1 minute without biting, you get a big reward. Then you go for 2 minutes without biting, you get a big reward, 5 minutes. Those are things to try. And I've seen variable success with something like that. That's full court press. You're with them all the time, but is something worth considering. Another is looking for co-occurring hyperactivity that might suggest that a medication treatment for hyperactivity might help reduce that. I've seen some situations where sensory-seeking behavior reduced when you gave a treatment for hyperactivity. And we may miss hyperactivity in individuals with Angelman syndrome who don't have the motor ability to be running around the room. So, question over here.
My son's 18 and he goes to his fingernail, but he's on basically like walk club, bar club.
Yeah.
Stack of them and he soaks them, gives him laundry, and keeps him occupied with his petting, doesn't need to rest. So he really just gets him sitting still and then hanging out or he's going to sleep. And just kind of gives him something to do and he's done it.
Yep. That's great. I've seen like a cord, like a phone cord that people will have with them or things like that. All sorts of things that are brought into the room. It's an incredibly common behavior. Yeah. Yes, right here.
Or
Yeah.
if you're sort of tracking that as well as some of the medications.
Absolutely. So I get this question really very regularly. It's a really good question. While there's no current study looking at CBD or CBD plus THC for any behavioral reason, there absolutely needs to be. And a lot of families aren't waiting for the perfect study to be designed before they go ahead and give things a try. So in this particular anxiety study, we tracked if individuals were on CBD, if there was THC in it, and whether they saw any improvement with it. That'll be one of the things that we report. We haven't done that part of the analysis yet, but that'll be one of the things we improve. Anecdotally, from my experience, the most common reasons families are trying it is either for sleep, anxiety, or irritability, in those sort of situations. And I've had only one family of maybe 10 or 15 families I've worked with that have tried it who've reported a worsening in irritability related to it. In most cases, there was no report of worsening symptoms. One thing I tell families to think about is CBD can increase the metabolism of certain seizure medications, so that's an important conversation to have with your neurologist. If it's going to be something that they try that start with just CBD, just hemp oil with the lowest amount of THC, before moving to including THC, because the individuals that had hyperactivity were more likely to have higher levels of THC. Probably the majority of families said maybe it helped, and then I've got maybe 5 or 6 families that say, wow, it really made a big difference. And we both use it in a dosed fashion and then sort of an as-needed basis. So you're right, we absolutely need research that's more on it. I have, as time gone on, felt more comfortable telling families it's something worth trying because I've just had so many families tell me that they tolerated it well, and some positive tolerability data from looking at its usage in seizures, suggesting that it may be really something worth trying. Yep. Yep. Yeah. Yeah, absolutely. I might have said that. I said that it's the safest place to start with just CBD before CBD that has THC in it.
I thought you'd never even want to try CBD or THC.
If you think about like some of the stories that like we heard today in terms of the severity and so treatment refractory, I can understand when families try it in terms of THC in it. What I always want is that for families to tell their providers what they're doing. Hopefully providers are open and hear this. I try to encourage families to try just CBD first before they try THC. I'm aware of the fact that living in the real world, some families are in a really stuck position and are trying some other things. And I'm open to hearing that and hearing about their experience. Okay. Oh, sorry, there's one right there.
So
Yeah.
my son has irritability, hyperactivity, maybe something like that. But he also, excitement. If one of, his grandmother comes, one of his favorite people, we will
Yep.
have a whole day of horrible behavior.
Mhm.
And just attacking and aggressive.
Yep.
So excited to see her that he was happy.
Mm-hmm. Yes.
Is there anything, how he is on
He's on 10X. Okay. Did you notice any change at all with 10X? Not really. Yeah. Okay.
We started with a milligram.
Yep.
And we saw that behavior. It was worse.
And so you came off it.
No, we
Oh,
took up the full
1 milligram,
1 milligram.
1 tablet. Yep.
It was great for probably a couple weeks,
Oh. Okay.
maybe a month, and there were reports come from school about a lot calmer, a lot longer attention span, but
Okay.
that went away.
Okay. Okay.
So I'm not sure, but I find that I hate when people are coming over, especially if they're just
Yeah.
coming for a day, because it is
Yeah.
horrible.
Yeah.
I mean, we have the irritability where people just start attacking, and it'll be a 15-minute attack
Mm-hmm.
too, and for not getting what he wants or attention or whatever. I mean, our biggest problem is
Yeah. Yeah. Absolutely. So if he's tolerating the dosage of the guanfacine and tolerating it well, I try to think about with guanfacine, you're going to kind of see the best effects in maybe the 6 to 8 hours after they take it. It's possible that's still a relatively low dosage of the guanfacine medicine. If there are side effects related to it, you can't go any higher, and that's that. But if it's being tolerated okay, trying to increase the dosage may be something worth considering. In other, I think about kids and teens and adults with Angelman syndrome being more sensitive to medications than others. But if we looked at other patient populations, developmental disabilities, a dosage might be 1 to 4 milligrams on that medication.
He's 7, but he's about 80 pounds. He's UPD,
Okay.
so I
Yep.
well, this is a lot more common.
Yes, absolutely. And I think also what drives a lot of the bigger concern in UPD as well is there's a higher likelihood of better motor function where you can do a lot more, you can cause a lot more havoc. Yeah.
He causes a lot of havoc.
Yeah.
I mean,
Yeah.
he'll go up to the TV and stare at you and then just shut up.
Mm-hmm.
To be like, look what I can do. I was not having cause concussions and his brother hit over the head with the iPad.
Yeah. Yeah.
There are some, I mean, he'll get a hold of you, there's no other way. He is very strong, he's a big kid, and according to the doctor, he's on the growth chart to be about 6 or 8.
Yeah. Speaking of anxiety, yeah, yeah. It's reasonable to consider trying a higher dosage. You would not be moving into dangerous dosages if you went up. I try to think about really getting to dosages that are effective before I give up. Yeah, absolutely. I hope that's coming across, that I am seeing families, and these are exactly the kind of stories or reasons for presentation that I hear.
It's our biggest problem with school with
Yeah.
anything going out. I mean, we still take classes, still do things, but he has learned if he doesn't want to go somewhere, he can go limp.
Yeah.
There's no moving him.
Yeah.
I used to be able to get up over his armpits, and he's learned why I can just put my hands straight up and slither out.
Yep. He's pretty resourceful.
He's very resourceful.
Yeah.
And yeah, he's a little
Yeah. Escape artist. Yeah.
the aggressive behavior
That's your main concern.
gets bigger.
Yep.
We won't be able to handle.
Absolutely. Yeah. I think it's reasonable proceeding with those treatments and giving those things a try. Absolutely. That's probably where the first place that I would start, assuming that he's tolerating it okay.
Yeah,
Yep.
mean, he didn't tolerate a half the dose. He was bad,
Yeah.
but the full dose.
Yeah. The signs of some improvement initially is encouraging, I'd say. Yep.
Can anti-anxiety medication be taken on just a when-needed basis only?
Absolutely, definitely. And I definitely think about those situations. The story that was told just here about just prior to visits from other family members, that's a really common scenario where I might recommend a medication just prior to a family visit or prior to a doctor's appointment. Those are that I've probably got 5 or 6 patients where that's the only way I'm prescribing the medicine, not on a standing basis. That's a really reasonable place to start. And you're sidestepping a lot of the risk if you're doing it that way. Good question. Maybe we've gone over a bit, so maybe we'll... Oh, hi. Thank you for your attention. Nice to meet you all. Come up to me afterwards if you have other questions. Nice to meet you all.